Good afternoon, everyone. My name is Deirmengian. I'm one of the joint replacement surgeons at the Rothman Institute. I'm here today to do a web chat for about an hour. We're going to go through a variety of questions that I see that you're sending in over the link, and I'll try to get through as many of them as I can. I do hip and knee replacements. I also do some partial knee replacements. We have a very large practice at the Rothman Institute with many surgeons doing replacements. All of the questions I answer today, I'll try to provide answers that are evidence-based. What that means is I'll try to make sure that my answers are not only my opinion, but also based on the general medical literature on we know what is true. So we'll start with the first question. What are the latest trends in hip and knee replacement surgery? This is a question that I get from a lot of my patients as people want to know what's the cutting edge. Are there things that can improve outcomes? Are there things that can make recovery faster? One of the things that I do on a yearly basis is write an article for the Journal of Bone and Joint Surgery, in which they've asked us to go through all of the new techniques in joint replacement surgery to give an idea of which ones really work and which ones don't. Over the next 10 years, I think we are going to see some changes in hip and knee replacements, and most of them are going to be around the medical management of patients. The implants we're currently using have really been around for many years now with very small improvements. And sometimes when we try to make improvements to the implants, it actually leads to unexpected issues that we really never had before. And right now in our field, people are pretty happy with the implants we have. They work well in general, they fit patients really well, we have more sizes than we ever had before. So I see over the next 10 years that we're really going to start focusing on patients, how their pain is, how fast they recover, all of the things we can do to make their post-op recovery better. The next question here. Tell me a little bit about how someone can rapidly recover from hip and knee replacement surgery. Well, there are many ways that somebody can rapidly recover from a hip or knee replacement. It was only 15 or 20 years ago that people actually were in the hospital for 2 to 3 weeks after a hip or knee replacement surgery. And in some parts of the world, people are still in the hospital for a week or two after surgery. In this country, we've really started pushing people to get better faster, get up and walk more quickly, and get home more quickly. And there's various things that people have tried to sort of accomplish this goal of getting home sooner. The first is perioperative protocols, and this is really what the topic of this webcast was today. What does perioperative protocols mean? Well, aside from the surgery and how we put the knee or hip replacement in, it's very important what medicines you give, how fast you get somebody up and walk them, and what directions you give them. If we told all of our patients to stay in bed for a week, of course that would be a slow recovery for unnecessary means. So what we do now is we have a whole sequence of medications that we provide before, during, and after surgery to set up the body for having surgery. The first thing we do is called preemptive medication. The reason it's called preemptive is instead of waiting for you to have pain, instead of waiting for you to have nausea, and instead of waiting for bad things to happen after surgery, we preemptively treat them. So before surgery, usually in the waiting area, we'll give some medications so that your blood levels of pain meds increase. During surgery, we also give several medications of various types. Pain medications, anti-inflammatories, anti-nausea medicines. Usually we like to use a spinal with sedation now so that you don't feel sick after surgery. And during surgery, we sometimes provide an injection with various medications, and this injection helps prevent pain to a certain extent as well. After surgery, we no longer give IV narcotics. IV narcotics make you feel nauseous, they make you feel sick and tired. So the medicines we give before and during surgery are usually enough to hold you over after surgery. And our pain scores after surgery are now about 3 out of 10, which is much lower than what they used to be in the past. After surgery, the nurses monitor the pain and make sure you take oral medications as needed to treat the pain. And the therapists see you almost immediately and get you up and walking on the same day. And using this perioperative protocol for a rapid recovery, most of our patients are able to go home within 1 to 2 days after surgery. Sometimes a patient will want to go home the next day and we can accommodate that. But for the most part, our patients have medical problems and we like to keep them in the hospital overnight to make sure they're doing well before they go home. Overall, this has really led to a faster recovery, and I think that most experts in our field would agree that this perioperative protocol, how we treat with medicines and physical therapy, is really responsible for about 99% of the improvements you've seen in the past 10 years in hip and knee replacements getting better faster. Now, aside from patients getting better fast because of the medicines we give them, I feel that we're also better at setting expectations. It turns out that if you tell someone they're not going to do well for a month, they usually don't do well for a month. If you explain to somebody that they'll be able to walk within 24 hours and maybe go home soon as well, people are more willing to do so if their expectations are set right. So a lot of the joint replacement field right now is moving towards setting patient expectations appropriately so people understand how fast they could potentially get better. A third thing that we've really seen come up over the last 10 to 15 years is minimally invasive surgery. And although at first we thought minimally invasive surgery was going to have a lot to do with getting somebody better, it turns out that it probably has a really minor role. When we first started doing minimally invasive surgery, we thought it would make a big difference. So at the same time, we explained to the anesthesiologists and the nurses and everyone in the hospital that we wanted the patient to go home the next day. And guess what happened? The patient went home the next day. And all the surgeons were proud. We thought it was all because of what we were doing with the surgery. As it turns out, over the past 10 years, we have figured out that even the surgeons who weren't doing the minimally invasive surgery, who used the new perioperative pain protocols, their patients were getting better just as fast. And it turns out that it had very little to do with how we did the surgery, but more to do with how we treated the patient with the medicines. So I think that the medication treatments, the protocols you use, and the physical therapy done really early getting out of bed are all critical to have a fast recovery. And most experts in the field now don't believe that the way you do the knee replacement or the actual technique is actually that important to getting better. And one of the reasons may be that almost everybody in the field now is doing some type of minimally invasive surgery compared to what we were doing 20 years ago. So that ends up not being as much of an issue, even though it's the one that most of my patients ask me. All right, we have another question from a guest. What does the future for joint replacement surgery hold? Well, we talked about this before a little bit, but I think we'll get into another issue which a lot of patients ask me about. How about stem cells? How about growth factors? How about all these other technologies that we've been hearing about in the news? Years and years ago, when they discovered the human genome, we believed that all these diseases would be cured and that we'd have new medicines and new growth factors and stem cells to really cure a lot of the diseases we have. And you'll see a lot of commercials in magazines and on TV from people that say that they can inject your knee with a gel or inject your knee with a growth factor or a stem cell to regenerate your knee so that you don't need a replacement. And although that's all of our dreams and that's what we want to do for people, it turns out that the mechanical problem with an arthritic knee prevents these other therapies from being successful. We can put cartilage in your knee, but it's going to be destroyed very quickly because you have an arthritic knee that's malaligned. Similarly, a lot of the injections and growth factors we've tried really haven't resulted in a lot of benefit. So even though we thought the future was going to hold a lot of technologies that help us avoid surgery, in reality it doesn't look like we're really that close to doing so. We're still doing research and hopefully one day we don't have to put in hip and knee replacements anymore. But it doesn't look like that's even coming within the next 10 or 15 years based on the research I'm seeing at this point. We'll go to the next question. Is there an age limit on knee replacements? This is a question that very many people ask me, and I get both sides of it. Can you be too young for a knee replacement, or can you be too old for a knee replacement? And what I tell my patients is, I don't make judgments based on age. I think age is something that really doesn't tell you how healthy the person is. I have a lot of patients in their 80s who are healthier than some of my patients in their 50s. So instead of looking at age, I look at the whole picture. Now I know some of my friends in joint replacements do have their own age limit in their mind. They don't like to operate on people over 85 or people under 50. But in reality, there are some patients over 85 who are having a miserable life because of their arthritic knee. And even though the risks are higher, and even though we explain that something could go wrong, they're willing to do it because they're hurting so much, and they don't want to live the rest of their life in terrible pain in a wheelchair. Similarly, we have people who are in their 30s who have such a bad hip or knee that they can't walk well anymore. And they're looking ahead at their family and their kids, and they're wondering how they're going to enjoy their life. So although we try not to operate as much in young patients, and we try not to operate as much in older patients because of the risks on both sides, in reality, we make these judgments based on the individual. If I see a 92-year-old patient who is in miserable pain, she can't live happily and it's ruining her quality of life, and I explain to her or him what the risks are, and they still want to have surgery, I'm willing to do that surgery in a 92-year-old as long as it's medically reasonable. And similarly, if I have a 25-year-old with a terrible knee who's tried everything in their power to make their knee better and nothing's working, and they've tried medicines and rehabilitation, they've tried using a brace, and they've gone on for years and now they're unable to walk, I would be willing to do that knee if it was really the only option. So although age is important to assessing the risk of a knee replacement, I don't think it's reasonable to have an absolute cutoff on age. The next question from Alan. What is the recovery time after you perform a total knee replacement? Do you have a long rehab? Well, that question can mean a variety of things, and again, this is something that almost all my patients ask me. What is the recovery time after a knee replacement? And to answer that question appropriately, we really need to understand what you mean by recovery. If by recovery you mean out of bed and walking, I would say the recovery time is a few hours. If by recovery you mean when are you home, it can be anywhere from 18 hours to 48 to 72 hours, depending on the rest of your health. If recovery time means when do you not have much pain and can you walk around your house pretty well, then recovery time may be 4 or 5 weeks. And if you mean when can I go back to work, it really depends on what you do for work. So my patients with a desk job are able to go back in about 4 to 6 weeks, sometimes sooner depending on how their knee feels. My patients who are carpenters or plumbers or people who really need to carry a lot of heavy weight, they take a little bit longer because their knee becomes more inflamed. When you do a knee replacement, you're cementing the knee replacement in. And when you cement the knee replacement in, that cement hardens quite quickly. It's called curing of the cement. It happens likely within the first hour it's completely cured. And what that means is that the knee replacement itself is very stable. It's pretty hard to ruin a knee replacement by walking too much in the first couple days after surgery. The problem is all of your tissues from having surgery done have been impacted. And there's a lot of swelling, your leg gets big, your incision starts to heal. And because of all those other issues, it's hard to walk a lot because your leg swells. Now, some people aren't swellers. Within a few days, they're able to walk around their house very comfortably and they're not having much trouble. Other people swell a lot, and for a month or two, they have trouble walking around a lot because of the swelling. So when somebody asks me what the recovery after a knee replacement is, it really depends on the person. It depends on how their leg feels. It depends on what they do for work. You really have to customize that answer for each patient. But I think I'll give you some general milestones and general rules that I think are safe. You should be up and walking usually within about 8 hours after surgery. That's reasonable for most patients. After a knee replacement, most people are home within about 24 to 72 hours, depending on your general health. Most people are able to walk comfortably at home within about 2 weeks after surgery, not thinking too much about the knee, but there's still a bit of swelling at that point. Most patients can get back to a desk job at about 3 to 6 weeks, depending on how their knee feels. And then people who have a job in labor take more like 6 to 10 weeks, depending on what exactly their job is. And then you can ask about hobbies and what you like to do for fun. Most patients who golf or play tennis are able to get back to those activities in about 2 to 4 months. I've had some patients get back as soon as 6 weeks, but that's pretty rare. And I've had some patients that take 6 months to get back to golf. That's pretty rare too. Most people between 2 and 4 months can get back to it pretty comfortably. My next question from Sarah. Do you use cement for all of your procedures? When you do a knee replacement, you have to have the metal from the knee replacement stick to the bone. You're not really replacing bone, you're more resurfacing it. And that has to have some way of sticking. And there's really 2 general technologies to do this. One of them is to cement the knee replacement in. Cement binds very well, and the track record for cement and knee replacements is excellent. They really do great. A second technology is called a non-cemented knee replacement. This is a knee replacement where the surface encourages bone to grow into it, and you basically mallet it into the knee hard enough that it gets stuck, and then the bone grows into it. Both of these technologies work. Both of them are reasonable. Historically, we've had problems when we don't use cement. So I bet you 80 to 90% of surgeons in this country cement all of their knee replacements because cementing has a great track record, it works well, and we're all very comfortable with it. There are some technologies for non-cemented knees, and although historically they may not have done well, it seems like the newer models are doing reasonably well. I think we need some more data on this to know that it works as well as a cemented knee. But they're both reasonable options at this point. My preference is for a cemented knee only because there's a great track record. I have put in non-cemented knees in the past and I'm pretty pleased with them. Every surgeon will have their own preferences for these. And as a patient, I advise not trying to dictate what your surgeon does, because your surgeon has their preferences for a reason. They're good at their own technique. They have a track record with their own technique. And if I had my own knee done, I don't think that I would have a preference between a cemented or a non-cemented knee. Both of them work well enough that I'd feel quite comfortable with them. The next question from Kim: how do you know if you need a hip replacement or if therapy can resolve the issue? Well, when somebody has hip pain, the first thing to point out is the word hip means something a little bit different to a surgeon than a patient. Most of my patients, when I say, "Where's your hip?" they point to their side. And when they come in complaining of hip pain, they may point to their side or their buttock area as the location of hip pain. But in reality, most patients with a true hip issue have pain in the groin, and that's the pain that's bad. So if you have pain in the groin, it means that it's possible you have arthritis. Of all of the causes of hip pain, there is greater trochanteric bursitis, there is sciatica, there is arthritis, there is impingement. I could go on and on with the things that can cause hip pain. And you always want to avoid surgery. So what can you do? Therapy can work, medications can work, sometimes using a cane for a little while can work. And it's important to see your surgeon so that they can tell you that nothing terrible is wrong. Now let's talk specifically about arthritis. If you have arthritis in your hip, how do you know if you have to have a hip replacement or physical therapy will work? And this is something that differs by patients. I've had some patients that have really bad hip arthritis. They try physical therapy, and almost miraculously, they feel better, and it's wonderful. And I encourage people to do that if it works for them. For my patients, I would rather them not have surgery unless absolutely necessary. Now, for other patients, if I ask them to do physical therapy, they come back in a week and they're really upset at me because the physical therapy caused pain. Fact of the matter is they have arthritis in their hip, and doing more activity causes more pain. So to a certain extent, the way your body reacts to physical therapy really depends on how your body reacts to it. It's different for every person. So I recommend to all my patients, if you haven't tried physical therapy, it's probably worth trying, unless your arthritis is so bad that you can't even walk well. So I would recommend to Kim, try physical therapy, see if it works. If it works for you, as long as the diagnosis is arthritis, I don't think any surgeon would push you towards having surgery. On the other hand, if you try physical therapy and the hip pain gets worse, and your x-rays show a lot of arthritis, you may not have an option but to have a hip replacement at that point, depending on how bad the x-rays look and how bad your symptoms are. Next question. What are the questions I should ask my doctor? This is from Michael. What are the questions I should ask my doctor before a total knee replacement procedure? Well, there are a lot of questions that are important, and there are some that I think aren't important that people tend to ask. I'll tell you the first things that are important in my mind are how comfortable the surgeon is doing a knee replacement. In the literature, it shows that if somebody does more than 20 to 50 knee replacements a year, they tend to get better results. It's a surgeon who probably has protocols in place at a hospital that has protocols in place. And when someone does a lot of something, they tend to be better at it and get better results. So if I was having someone do my knee replacement, the first thing I would look at is how many knee replacements do they do? How comfortable are they? Are they an arthroplasty surgeon, which means do they do a lot of knee replacement surgeries? The second question that would be important to me is what hospital I was at. I would want to make sure I feel comfortable at that hospital, that it was a place that I had confidence in. And sometimes that's hard to know from the start, but by word of mouth you can get that information. The third thing that I think makes a difference to me personally is how alert is the surgeon to knowing the literature? There is really a lot of literature now on knee replacements. There's a lot of research. There's a lot of things that we know are true. So instead of the surgeon just using his own opinion, he's using his medical knowledge based on a lot of papers that have been published. And one of the things we really push at the Rothman Institute is doing research. We publish really a ton of papers every year on various aspects of joint replacements. And by publishing those papers and doing the research, we're making progress in understanding what things work and some don't. There are some ideas we've had in the past that sounded great. And then when we did the research to try to prove that it worked, it showed that it didn't work. And then you bail on the idea. There are other ideas we've had that we didn't think would work that great. And when you look at the data, it makes a giant difference. So evidence-based medicine is really important, and to me that would be important for my surgeon. What questions wouldn't I ask my surgeon necessarily? There's a lot of recent emphasis on how the surgery is done. Do you cut this? Do you cut that? Do you do minimally invasive? As it turns out, that probably doesn't make a big difference to a joint replacement. There's a lot of evidence to show that the outcome is independent of those techniques. I have a lot of patients ask me if I can use certain implants or if I can use certain types of joints that they saw on a commercial make them better faster. There is no evidence in our literature to show that any knee replacements are better than any other knee replacements. So that's also a question that tends to waste time in the office of the doctor. I think you should spend the time asking questions about your expected recovery, about what your expectations should be, about what you need to do to get better quickly, and really avoid the questions that seem to eat up a lot of time that really don't make a difference. And in my mind, those are the types of implants that are used and the type of approach to the knee, which has now been shown pretty clearly not to make a big difference to the patient. The next question here, and the questions will now start coming up on the screen too so that you can see exactly what is being asked. I am in need of a knee replacement, but was told that the risk was too great because of my blood clot history. Is there a safe way for me to be able to have a knee replacement without risking death? Well, the first thing I'll say right off the bat is any surgery you have, no matter what it is, there is a risk of death because you're going to have anesthesia and you're going to have an invasive procedure which could potentially lead to death. Now, luckily, of all of the surgeries out there in medicine, hip and knee replacements have a very low risk of death. We almost never see it happen. It's probably about 1 in 1,000 or 1 in 10,000 patients. And usually the patients who end up dying are patients who we identified before surgery as a big risk and really warned them a lot. Now, if you have a history of blood clots, the concern is that you could form a blood clot after surgery and that blood clot could go to your lung, or the blood clot could actually form in your lung, causing trouble breathing after surgery, which can risk to a big problem. Now, there are many patients in our population who have problems with blood clotting. There's a disease called factor V Leiden. Anybody who's on estrogen pills or estrogen patches, people who get hormone replacement therapy are on birth control, people who have other diseases like high platelet levels can be at risk of clot. So I see these patients who have these various issues in my office on a regular basis. And the key is managing the risk. You can't get rid of the risk, but you can manage the risk and you can try to reduce it. So before surgery, we can run tests to make sure we understand what the risk of blood clotting is. We could go over expectations after surgery and go over the various things we can do to try to avoid a blood clot. Unfortunately, blood thinners don't appear to make a big difference for blood clots, but sometimes blood thinners are a strategy that hematologists will recommend. We can recommend walking as quickly as possible. We can recommend using a spinal for your anesthesia, which reduces the risk of blood clots. We can recommend using boots on your calves right after surgery, which helps reduce blood clots. So there's various things we can do to manage the risk, but there's nothing you can do to completely remove the risk. I hope that has answered your question sufficiently. The next question is from Fred Robinson, and we'll put it up on the screen here. What is the average recovery time for a hip replacement for a person who does physical work? When should they be able to return to their physical work for full time? Physical work is tough after a joint replacement, not because the joint replacement can't take the pressure, but because your skin and your muscles and your deep tissue become inflamed after a surgery. When that happens, you get a swollen leg, and after surgery, even if you rehab great, the swollen leg might make it difficult to be on your feet all day. Usually people who do physical work, it's pretty unreasonable for them to go back to work happy within 6 weeks. I've had some of my patients do that, but they do have some persistent swelling. I think a reasonable thought for somebody who's a plumber or a carpenter going back really to full-time work is more like 8 to 12 weeks. And the reason I say that is I could try to say sooner to convince someone to have a hip or knee replacement to get them back faster. But the swelling after surgery, no matter how you do the knee or hip replacement, ends up getting worse if you do physical work after surgery. Now, some patients aren't swellers. We talked about this earlier in the web chat. Some patients just don't swell a lot. And if they can get back to physical labor at 5 weeks and they're not having pain or swelling, I'll allow them to do it. There's other patients who are terrible swellers, and for 4 to 6 months they have trouble being on their feet for more than 8 hours because their leg swells. So it really depends on how your body responds to surgery, but I think most surgeons would give a really rough estimate to say somewhere between 6 weeks to 3 months you should be able to return to pretty strenuous physical work reasonably comfortably. Now, hips and knee replacements definitely have some pain for about 6 months to a year, so there will be some pain involved here or there, but overall the pain should be mostly gone by 3 months. The next question here. I was told I could use a partial knee replacement. I am 55. Is it better to wait or get a full knee replacement? This is a very interesting question. When partial knee replacements came out many, many years ago, they didn't do that well at first. And there was 2 reasons for that. One reason is the implants that we had for partial knee replacements just didn't work as well as they do now. And the second reason is that we didn't know who was the right patient to get a partial knee replacement. For both of those reasons, partial knee replacements weren't used as commonly maybe 10 to 15 years ago. The most recent evidence on partial knee replacements is that they last just about as long as a total knee replacement. In many of the national registries, regular knee replacements last about 15 years. 92% of them are still in. And in those same registries, about 88% of the partial knee replacements are still in. So the difference is pretty close. I don't see age to be as big an issue here. Some surgeons think that the age is an important issue, but if you're 55 and that's young, I don't see that as a big issue. The real question is your arthritis only in one compartment of your knee, or is it all over your knee? It's not a matter of how bad the arthritis is, it's a matter of where the arthritis is. You can have terrible arthritis in one part of your knee, and that terrible arthritis may be able to be treated with a partial knee replacement. Similarly, you can have more mild arthritis everywhere in your knee. And even though your arthritis isn't that bad, you can't have a partial knee replacement because it's everywhere. So the first thing is your surgeon has to make sure that your arthritis is only in the one area of your knee to do a partial knee. And if the surgeon selects you properly and you could get a partial knee replacement, and if the implants he's using or she is using, which should be the most recent models, are working well, you really should get about 10 to 25 years of survivorship of that partial knee replacement. So in my mind, it doesn't make sense to wait for a total knee replacement. It doesn't make sense to wait for any different technology. If you need a surgery for your knee, a knee replacement that is full or partial may both be reasonable. If you get a partial knee and the decision was appropriately made for you, it really ought to last just about, if not as long as a knee replacement. Now, one thing to make clear is a partial knee replacement is not that much easier than a total knee replacement. You should never do a partial knee replacement with the expectation that you'll be back soon to get a total knee. So I've had some patients say to me, Carl, just do a partial, and then if I need one in 5 years, I'll have a total. Well, it's not that easy because the partial knees aren't that easy to convert to a total knee. So if I personally am going to do a partial knee for somebody, I have to feel in my heart that it's going to last as long as a total knee replacement. If that's the case, I think a partial is very appropriate even if you're 55. If you could wait for a total, maybe you're not having enough pain to even have a replacement. Most of my patients who are having a replacement tell me that they can't wait longer because they're having so much pain. But I do a reasonable number of partial knee replacements. In my experience, they do very well. And it's certainly an alternative to a total knee replacement for some patients. The next question. I was thinking about having a knee replacement surgery, but my range of motion is very, very poor. That means the knee isn't moving very well. Can it be restored after total knee replacement? It looks like active extension is to -30 and flexion is to 110. Susan, I got your question, and it turns out that even though your knee bends reasonably well, you can't straighten it out and it's stuck. And there's a variety of reasons that this can happen. Sometimes arthritis can be so bad that you can't straighten your knee out. Or sometimes there's a traumatic event or an injury, and the result is that you can't straighten your knee out. When we look back at all of the knee replacements done over the past 20 years in our country, and many different universities have shown this now, it turns out that the biggest risk for having a stiff knee replacement after surgery is if you had a stiff knee before surgery. So Susan, your knee will have a higher risk of being stiff after surgery. And it's a chance you're going to have to take if you want to have a knee replacement, because no surgeon would guarantee you that they could get you a guaranteed good range of motion. But in my personal experience and the experience of most of my colleagues, if somebody has bad arthritis and their knee doesn't move well, we have a reasonably good chance of getting your knee moving well after surgery. I would say 80 to 90% of my patients who have a stiff knee before surgery have significantly better motion after surgery, especially if it's as dramatic as this. But whenever I'm taking care of a patient who has such a restricted range of motion, I make it really clear that one of the risks is that after surgery you still can't move your knee well, because nobody can guarantee how your body is going to respond to surgery. I hope that answers your question. Here's the next question. What is the recovery time for a knee replacement, and what is the duration of a new knee? We already talked about recovery time really a good bit, so we'll focus on what is the duration of a new knee. Knee replacements have been around for quite a long time now. We have a lot of good data on how long knee replacements last. When we look back at the previous generations of knee replacements, that's the only way for us to know how long they last, right? Because they have to be in that long for us to know that they're still around. So when we look back at the knees about 15 years ago, about 90 to 94% of them are still in, functioning reasonably well. And based on that data, we tell people that a knee replacement ought to last about 15 to 25 years, somewhere in that range. They could last longer, but they also might fail sooner. Just like anything else in nature or biology, there's a lot of variation. I've seen patients who've had a loose knee replacement within 2 to 5 years after surgery. Sometimes it happens because there's an infection, but other times it just comes loose and we don't know why. I've seen other patients who have a knee replacement from 30 years ago that was known to be a terrible model, and it's still in working well. So there's a lot of variation into how people do, but I think most surgeons tell their patients that it should last about 15 to 25 years based on the data we have. Now there's an interesting issue in orthopedics. Every 8 years, a new knee replacement comes out, and the companies make the new knee replacements with the hope that the new model lasts longer. And they even sometimes advertise that the new model will last 30 years or 40 years. The problem is, if the knee replacement just came out, you don't know that it's going to last that long because it's hard to predict what's going to happen in the human body. And sometimes a replacement that was predicted to last a very long time unexpectedly has a very early failure rate that's higher than expected. So the best I can tell you is that the knee replacements we had out 20 years ago, most of those are still in. Since then, the companies have made many changes and the surgeons have made changes to try to make them last longer. And our hope is that they do last longer. But we're not going to know how long today's knees last until we're out 15 to 30 years to see how they really did. And unfortunately, that's the best answer we can give. But if I needed a knee replacement, my assumption would be that it would last somewhere between 15 or 25 years. The next question from Joe. The question is, I know I need a knee replacement. My problem is that my wife is going to have trouble taking care of me and I can't take forever to recover. I see TV ads for Virtua in New Jersey stating that they don't cut the quad tendon, which makes recovery faster. Is anyone at Rothman doing this procedure? I'm really fortunate that I can talk from a lot of experience in this. I was a fellow about 10 years ago now, maybe 8 to 10 years ago, and I did my training at Rush University where the quad sparing topic started. And at that time when we were doing the surgery, we thought we were doing this amazing surgery that was going to have amazing results. And I have mentors at Rush University who are really amazing surgeries that did an amazing job. There are commercials now about quad-sparing knee replacement, and they say certain things, but I'm going to stay more general in my conversation here. There's a couple things that you'll be very surprised to hear about the quad-sparing knee replacement. The first thing is, it is not a new approach and it is not a new technology. I wrote one of the first papers ever with Richard Berger and a group at Rush, several papers, almost 10 years ago now. And those were the first papers describing how to do a quad-sparing knee replacement. In my mind as a surgeon, it wasn't a new procedure, so I'm somewhat surprised to hear some people commenting on that. But it's not a new procedure, and you shouldn't think it is. The second surprising thing is, when I see certain people talking about quad-sparing knee replacements, and they say they don't cut the quad tendon, my patients come in and ask me whether I'm going to cut across the quad tendon. And I think most people are shocked to hear that nobody cuts across the quad tendon when they do a knee replacement. Nobody in our country does that. So I want to be clear on what a quad-sparing knee replacement is. It doesn't mean that other people do cut the quad tendon across the tendon to sever it. And I'll give you an example of what I mean. If you look at a swing, on a swing set, swinging back and forth, and somebody came in the house and said, "Johnny cut the rope on the swing," I think your assumption would be that Johnny cut across the rope and now the swing doesn't work anymore. That's not what's going on with the quad tendon and the quad sparing knee replacement. To be clear, no surgeons in this country cut across the quad tendon. That would be a catastrophic complication because your knee wouldn't work. When we first wrote about the quad sparing knee replacement, it was a variation of minimally invasive surgery. There are many types of minimally invasive surgery that almost everybody does now. It's not unique. You can do a quad sparing approach. You can do a mini medial parapatellar approach. You could do a medial subvastus approach. You could do a medial midvastus approach. There are many different mini-invasive approaches that people have tried through history. And we've done a lot of experiments to try to figure this out. So what we do is we get two groups of patients. One is, let's say, a quad sparing group. The one is a normal group. Or one is a medial midvastus approach, and the other one is a subvastus approach. And we won't even tell the patients, this is part of a study, the patients agree to have this done. One group has one surgery, one group has the other. And then we follow these patients over the next days and weeks. We ask them about their pain, we ask them about their physical therapy, we ask them how fast they got back to work or how fast they felt good. And the shocking thing is both groups always do the same. So when I look at this quad sparing issue, I've had an evolution in my practice. The first 2 years in practice, and this was almost 10 years ago now, all I did was quad sparing knees. I was taught at Rush University. I believed it made a big difference, so I used quad sparing knees. But then all these studies started coming out in our literature saying that the quad sparing technique does not lead to a faster recovery than any other minimally invasive approach or even standard approach for that matter. There are now 6 studies that looked into this question. The most recent one, I believe, was from Yale. And what they found was that whether you do the surgery by a quad sparing technique or any other technique, there does not appear to be a difference in the recovery at all. And this is a controversial topic, especially in our area. Recently, the Better Business Bureau looked into this, and I saw on the front cover of the business section of the Inquirer that they actually asked those commercials to be pulled, saying that there was a faster recovery from the quad sparing surgery, because every paper ever published on that topic that tried to figure out whether it led to a faster recovery concluded that it did not lead to a faster recovery. There are many surgeons in the Philadelphia area that can do a quad sparing knee replacement. I can do a quad sparing knee replacement. Various Rothman surgeons can. I know there's surgeons from Penn, from Temple, and from Hahnemann that can do a quad sparing surgery. But amongst the surgeons who do the research on this and really know a lot about different approaches and evidence-based medicine, we haven't made a big deal about these approaches because we haven't been impressed with the results. Like I said when I started the web chat, the biggest difference to a faster recovery is what medicines you give the patient, avoiding IV narcotics, giving the right type of anesthesia, getting you up on your feet quickly. When we do all those things, the patient can usually go home quite quickly from the hospital and even get back to work within about 3 to 6 weeks. And so far, I have personally no reason to believe that it's accurate to tell my patients that I can do a certain procedure to get them better even faster. Now, 8 years ago, when we started the quad sparing technique and all the surgeons were trying it, we truly believed that it made a big difference. But we were shocked when the surgeons that weren't doing quad sparing replacements got the same results with the medications and some of the other things we were doing to get people better faster. So my personal opinion and the opinion of the literature right now, evidence-based medicine, says that the quad sparing approach is not a special thing. It does not lead to faster recovery. In fact, there's a lot of data to show that it gives equivalent results. So I usually have this discussion with my patients. They're usually shocked to hear that nobody in the world cuts across the quad tendon when they do a knee replacement. And they're shocked to hear that it's not a new procedure. And I think a lot of that education is really valuable for the patient because going into surgery, it's very important to be honest, set appropriate expectations. And I want my patients understanding what's really important for a surgery. And that is a surgeon who does a lot of joint replacements and a perioperative pain protocol and therapy protocol to make sure the patient gets better quickly. But you really shouldn't go into a surgery thinking that it's going to be done some special way to make it better, because so far all the data we have shows that that is not true. The next question. What is the recovery time for a hip replacement? I am 53 years old and work in construction. What is the duration of the new knee? We've touched on a couple of these, but I'll talk about it one more time here. The recovery for a hip replacement really depends on various things. It depends on what you mean. You'll be able to walk almost right away. You'll be able to go home within probably 1 to 2 days. Especially if you're 53, you ought to be able to go home the next day. And once you're home, you'll probably be good enough to walk around your house comfortably within that week or two, and back to a desk job within about 4 to 6 weeks. Now, if you're in construction, John, who sent this message, is in construction. Not only does he have to lift things and be very physically active, but he has to be on his feet for a really long time. And the major problem is swelling. If your leg swells a lot after surgery, it may be tough to do a 10-hour shift in construction. I think your best bet is to assume that it's going to take at least 6 weeks for you to comfortably get back to construction, and it may take up to 8 to 10 weeks. That's a safe bet, which you should tell your employer. Rarely I have a patient who's ready by 4 or 5 weeks to do construction, and rarely I have someone that really needs 3 whole months. So it's right in that range there. The next question. How long will it take before driving after reconstructive hip surgery? This is an interesting question because after surgery there's a variety of things that matter, right? Your function matters. You have to be able to push a pedal. Your mental function matters. If you're on pain medicine, you want to make sure it's safe to drive. So a lot goes into this. As far as I know, there's a couple of good studies that have been done, but one that sticks in my mind where they're actually taking patients after surgery and testing their reaction time after putting a TV screen up with a car and seeing how fast they can react. And this was done years ago. It's not a very recent study. But they showed that it takes about 4 weeks to get your reaction time back completely. And it doesn't even matter which leg it is. That's the interesting thing. It probably has more to do with the medications and just having a surgery. Most surgeons now recommend that you can drive within 3 to 5 weeks. We've gotten a little bit better about recovering people more quickly with the medicines that I talked about. So I think 3 to 5 weeks is the best time, but it's something you should ask your surgeon and go with their preference because each surgeon has a good idea in their practice what is safe for them. Here's the next question. I am overweight but need a hip replacement. While I understand this, what is the maximum BMI that is acceptable? Meaning 20 to 50 pounds to 100 pounds overweight. Where does it become unacceptable for surgery? Thanks. And this is from Laura. Well, Laura, there's a variety of considerations in the overweight patient. And the biggest consideration that if you're overweight, various risks go up after surgery. For example, when we look back at our infections over the past 10 years, it's amazing how infections tend to occur in the overweight patients. When we look at patients that had a problem from sleep apnea in the hospital, they happen more in overweight patients. When you look at problems, other complications, other medical complications, the ability to get better quickly, perioperative issues that may occur, they tend to happen at a higher rate in overweight patients. So as a surgeon, it's important to let your patient know that there's a risk. And again, just like the patient who asked about blood clots, where you have to manage that risk, you have to manage the risk with being overweight. Now, how you manage it is extremely controversial. Some surgeons place a threshold on their practice where they feel it's unacceptable to do surgery. I've heard 38 as a BMI. I've heard 40. I've heard some people say 45. But we know that once the BMI starts creeping above 38, you start to see the risk of infection going up. So my preference usually is that if a patient is overweight to the point that their BMI is over 38 to 40, I usually request that they try to lose weight before surgery in the hopes that it reduces that risk. And the philosophy of each surgeon is different depending on how you've been trained and what you believe to be true, because we don't have a ton of hard data on how we can adjust the risks of being overweight. But you should definitely have this conversation with your surgeon. There is increased risk if you're overweight. There is a risk you'll get an infection. There is a risk your wound won't heal well. We definitely see more problems in such patients, and it's something you need to understand. And to answer your question, it's different for each surgeon. I don't think there is a right answer here. I think each surgeon looks at their own practice and tries to make a decision on where they feel it becomes unsafe. The next question. I have a 17-year-old son with Perthes disease. He had a left leg lengthening in 2010. He had left hip reconstructive surgery in August of 2013. We were told that hip replacement would be in his future. What is the projected time if he were to need or have replacement surgery? Perthes disease is a disease where a young person can develop an abnormality in their femoral head and develop early arthritis. It's actually not that uncommon. Every surgeon sees this in their practice, and it's unfortunate to see such a young person who may need a hip replacement. There are various surgeries that people try to make Perthes disease better in a hip, and sometimes when those procedures don't work, the only thing left is a hip replacement. And like we discussed earlier in the web chat, you want to try your best not to do a hip replacement in a young person because they don't last forever and then they're going to need a second surgery. But I've personally operated on an 18-year-old gymnast. She could hardly walk anymore. Her life had become ruined. And she had a similar problem, which I operated on, and she did great with her hip replacement. It's impossible to predict how long it's going to take. I've seen patients under 20 years old who needed a hip replacement. How do I know they needed a hip replacement? They couldn't walk anymore. They really had difficulty. They had terrible pain every day, and they couldn't live life like that. And the x-ray looked terrible too. On the other hand, I've seen some people get into their 30s or 40s. Their Perthes wasn't that bad. It never became very painful. Their x-rays never looked that bad. But over time, it slowly developed. So you really need to see a surgeon. They need to look at the x-rays, and you need an answer that is tailored for your son, because I can't give you a general answer. It really differs by patient. The next question: what type of post-op rehab of a knee can be expected? When you have a knee replacement, after surgery, there's a period of rehabilitation where you get better. And a lot of that rehabilitation time is the swelling going down and the pain getting better. And part of that rehabilitation is getting your knee to move better. In the past, there was something called a CPM machine, a continuous passive range of motion machine, that your knee would be in the hospital to move the knee after surgery. It turns out that machine doesn't really help, so most surgeons have gotten rid of that machine now. You should expect that on the day of surgery or the next day, you should be able to get up and walk. Maybe it's 10 feet, maybe it's 300 feet, but you should be able to walk. That reduces your chances of getting a blood clot, and it gets your knee moving. Over your next time in the hospital, maybe over the next day, you'll be walking some, and then you get to go home or to a rehab facility. I think most people know this now. There's a trend to avoid rehab facilities because most of our patients can walk well enough now that they can actually go home after surgery and do well at home. So sometimes a physical therapist comes to your house, and what we're seeing increasingly now is that our patients don't need a physical therapist to come to their house. Sometimes we send them out to a physical therapist. And now and then we also see a patient whose knee worked so well after surgery that we don't push them towards physical therapy, and their knee seems to get better on its own. So we don't emphasize physical therapy quite as much as we used to 20 years ago, because as we've gotten better at doing a knee replacement, we're seeing better results. And as we've gotten better with the pain medications and getting people walking quickly, we don't see as many stiff knees as we used to see. Our rate of stiff knees has dropped over time, and it's down to about 4% now. You can expect physical therapy after surgery. For some people, it's a grueling experience if they have somewhat of a stiff knee. For other people, it's not a big deal and they get through it pretty easily. But I think this question really depends on your surgeon. Some surgeons push physical therapy really hard and they want you to get that range of motion going quickly, even if it hurts. Other surgeons are a bit more passive and let you go for a few weeks without a lot of therapy so that your knee can calm down first. But my impression is that most surgeons have some type of therapy in the hospital before the patient leaves to make sure it's safe for them to go home, and some after surgery as well, depending on the surgeon. I hope that answers your question. The next question from Rita. Is it better to stay longer in rehab before going home after bilateral knee replacements? And I think the best answer generally to that is no. We don't like our patients being in rehab too long. But it has to be medically safe to go home. So this question really depends on how you're functioning after surgery. Some people have bilateral knee replacements and they do really well. They don't even have to go to a rehab facility. Some can go home right after surgery. Other patients that have bilateral knee replacements, especially if they were weak before surgery, may need time in a rehab facility. The appropriate time to go home after rehab really depends on how well you're walking, how well you're able to do stairs, and what your needs are at home. If you live on a one-story apartment and it's easy to get around, you're going to be going home sooner, leaving rehab sooner. On the other hand, if you live in a 3-story house and before surgery you couldn't even do the stairs because you were too weak to do it, you're going to need more time in rehab. So in general, my opinion is that I like my patients to leave rehab as soon as possible because I think it's safer to be at home. It's better to be at home. But you do have to make sure that you pass certain milestones at the rehab facility. Make sure you can walk well. Make sure you can climb stairs if you have stairs at home. Make sure you can take care of yourself. All of those things are critical in order to go home safely. The next question from Debbie, what are the best ways to prevent infection? So infection is the complication that a surgeon dreads most because we have very little control over it. Most surgeons that I know exercise impeccable sterile technique and they do a lot of things in their practice to avoid infection. And sometimes it still happens. But I can tell you the things that we have found to be most important to prevent infections. The first thing is before surgery, you have to be able to manage all of the risks. A person with uncontrolled diabetes has to get it under control. A person that's very overweight has to get their weight down. A person that has an ulcer on their foot, you better wait for that ulcer to get better before they proceed. Sometimes people have a bad rash over their knee that has to get better. Sometimes people have an active infection somewhere else in their body. You have to make sure that the person having surgery is in the best shape so that they don't get an infection. And that's probably one of the most important steps to take. Now, during surgery, there's many things we do to avoid infections. Almost every surgeon that I know now gives an antibiotic right before surgery and gives a few doses after surgery to avoid infections. That's been shown very clearly in the literature to make a big difference in avoiding infections. The second important thing during surgery is to exercise impeccable sterile technique. We use different solutions to sterilize the knee. We use various draping techniques to make sure that nothing that's contaminated touches the knee. During surgery, we use layers of gloves that we change during the surgery to keep things clean. So that's very important. Now there's two things that a lot of people ask me about. One is, what about a special room that has an air vent to prevent infections? Most operating rooms in our area have that. But I have to say the literature, especially the literature out of the Mayo Clinic, shows that these laminar flow rooms probably don't stop infections from happening. Unfortunately, that's what the published studies show. So even though we use these rooms to try to avoid infections, they're probably not effective at avoiding infections. The second thing is, many of you may have noticed that your surgeon wears a spacesuit during surgery. There's a reasonably good literature showing that that doesn't improve the infection rates. So a lot of the things that we do which we believe help infections don't really help infections. And the most important thing is, again, preparing you well before surgery, making sure your risks are low, and also using the appropriate antibiotics. Now, a third thing is after surgery. You have to take care of your wound. You have to make sure it doesn't drain. You have to be careful and tell your surgeon if it looks red. These things are all important. There are books written on this topic, and I've written some about this. A lot of my partners have written about this. There's really a lot that goes into avoiding infections, but what I've told you are the things that are the easiest to understand and the things that are most effective. The next question here, from Debbie. I don't know if it's the same Debbie or a different Debbie, but it's from Debbie again. What is the difference in recovery time with a partial or total knee replacement? A partial knee replacement in recovery time is not a ton different than a total knee replacement. There are some differences. Usually the partial knee replacements seem to have a little bit less pain. The partial knee replacements seem to walk a little further in the beginning. And the partial knee replacements appear to have about a week or two faster recovery in general. But when my patients insist to me that they want a partial knee replacement, I am very clear to say that the difference is not giant. I would never do a partial knee replacement only because it gives you a faster recovery. The way I manage my own patients is I look at their arthritis and I see where the arthritis is. If they have bad arthritis only in part of their knee, then I do a partial knee replacement to treat that part of the knee. And there's some evidence to show that patients with a partial knee replacement prefer that knee over a total knee replacement and seem to have somewhat better function, but it's not a world of a difference. If I needed my knee replacement done and I was a candidate for a partial knee replacement, I think I would want a partial knee replacement, but I wouldn't feel disappointed if during surgery the surgeon had to do a total knee replacement because he didn't think a partial knee replacement was right. So it's not the kind of thing that makes or breaks your recovery. It's not that big a difference. But for my own patients, if I think they're a candidate for a partial knee replacement, I prefer to do them because I do think they work a little better and give a bit of a faster recovery, but not so much that I'd be very insistent on a partial, especially if it wasn't the right answer for that patient. Another question here from a guest. Discuss quad replacement surgery. Quad sparing surgery. We talked about this a little bit earlier, and I'll just emphasize a few points that everybody should know about quad sparing surgery. The first thing is the quad sparing surgery is not a new technique. It's not a groundbreaking technique that just came out. This surgery has been out more than 10 years now. I personally published a paper describing this technique about 8 years ago with the group out at Rush University. And 8 years ago, when I started my practice, all I did was quad sparing knee replacements. This was about, again, 8 years ago. So that's one shocking thing that, at least in my own family, from seeing some commercials, they hear me say that and they can't believe it. The second thing is, nobody actually cuts across the quadriceps tendon when they do a knee replacement. Nobody ever did. If you cut across the quad tendon during a surgery, that would be considered a catastrophic complication. And when my patients ask me if I cut the quad tendon, I always say to them, nobody cuts across the quad tendon. You can imagine a swing set. If you cut the rope, that's a bad problem. Nobody cuts the quad tendon like that. So you shouldn't be fearful of going to a surgeon that doesn't do quad sparing surgery because they're going to cut your tendon. That's really been overblown, and that's not a true thing to believe. And the final thing I'll tell you is, over the years, there were a lot of surgeons that did quad sparing surgery. I know surgeons at the University of Pennsylvania, at Hahnemann, surgeons various in New Jersey, New York, myself, some of my partners. And this was about 8 years ago. And over time, it came to our attention that the quad sparing technique really didn't lead to a faster recovery, and people have published that result. You can do various techniques to get a good result after a knee replacement, a great result. A mini midvastus, a mini subvastus, a mini parapatellar, a parapatellar, or a quad sparing. And all of the major studies that have been done comparing these techniques show no difference at all. So if I was personally having my knee replacement done, I would not even care how my surgeon did it, as long as that surgeon was good at putting in a knee replacement, because there's no evidence to suggest that the method makes a difference to the outcome. I believe the most recent paper was out of Yale, if I'm not mistaken, or it was out of a group in Connecticut, where they directly compared their quad sparing surgeries to a non-quad sparing surgeries, and they saw no difference. No difference in pain, no difference in how fast people walked, no difference in return to work, no difference in sports. So I personally don't make this a big issue with my patients. I can do a quad sparing technique, I can do a mini midvastus, I could do a regular knee replacement, but again, I want to emphasize, the biggest revolution in knee replacement in the last 10 years has been the rapid recovery perioperative pain protocol. That means the right medicines, the right anesthesia, the right early therapy. When you combine all these things, you can get a patient home the same day or the next day, and they will have a wonderful result. So I don't want anyone thinking, none of my patients, that they're going to have their quad tendon cut, because nobody's going to cut across their quad tendon and cause a break in the integrity. And I don't want my patients thinking it's some new interesting technique, because it's been around for 10 years or more. I think that's all for the questions today. We're at about an hour. I really appreciate the questions we got. I hope we gave some good answers and there was some good learning. And hopefully we're back sometime in the future.